warahmatullahi wabarakatuh. Welcome back guys to the channel of a summary of standard medical textbook, that is nothing but standard medical notes. So now today we will learn about the specific common causes which contribute to pleural effusion and their course and as well as their treatment. So let us begin. So number one, first we will begin with exudative pleural effusion. So remember the causes. One is bacteria, common causes of effusion, bacterial infection. Second one is tuberculosis. Third one is malignancy. Okay, malignancy. After these three, you can consider fourth, chylothorax. Fifth one, hemothorax. Okay, so these three are commonest causes of effusion. So first one, exudative pleural effusion in the course of bacterial pneumonia. Exudative pleural effusions are relatively common, but the development of empyema following a parapneumonic effusion is much less common, with prompt antibiotic therapy and fluid drainage used as needed. So empyema will not develop if you give proper antimicrobials at the time and fluid drainage is performed as needed. Now classification according to it is a spectrum actually. So when there is effusion due to bacterial infection, it progresses from uncomplicated to empyema. So we will divide into three different classes and discuss those three very briefly. Okay. So number one, classification of pleural disease secondary to bacterial pneumonia. Number one is uncomplicated parapneumonic effusion. Second is complicated parapneumonic effusion. The third one will be empyema or frank pus. So these are the three stages which a bacterial infection passes through. Uncomplicated parapneumonic effusion causes can be bacterial pneumonia, lung abscess, or infected bronchiectasis. So remember, to differentiate from complicated parapneumonic effusion or empyema, you need to remember the pH, LDH levels, and glucose levels. These three help us to differentiate between these three classes. Okay. So the effusion fluid is clear, has a pH more than 7.2, LDH levels less than 1000, glucose levels more than 60. No bacteria will be there. Okay, in the stained specimens or in culture. Cell counts. What are the cell counts? So with these three, you remember fourth one as cell count. There will be neutrophilic reaction, and if it is a tubercular associated tubercular effusion, there will be lymphocytosis. That's a uncomplicated parapneumonic effusion. Now coming to complicated parapneumonic effusion. Now there will be bacterial invasion. So that results in fibrin deposition and development of loculations in the pleural space. So now what will be the features? Pleural fluid can either be cloudy or clear, but it is not yet purulent. Either it can be cloudy or it can be clear. So how do you differentiate it? pH will be less than 7.2, LDH levels will be more than 1000, glucose level will be less than 60. So these things will indicate it is complicated. Bacteria will be observed in gram staining and culture. Okay. And in these cases, pleural drainage is usually necessary. Okay, so pleural drainage is necessary in complicated parapneumonic effusion and empyema. Remember, in small effusions with uncomplicated parapneumonic effusion, just treating with antibiotics is enough. But if there is effusion and it is complicated or it is empyema, then you should have drainage also along with antimicrobials. Moving forwards, coming to empyema. Causes of empyema: complicated parapneumonic effusions including TB. Okay, this is the most common cause. Less common causes include thoracic surgery, chest trauma, esophageal perforation, thoracentesis itself, subdiaphragmatic infection. Okay, Most common cause is complicated effusion. The effusion is purulent now. Purulent. It is cloudy and it is often foul smelling here. Okay. Foul smelling. Okay. And now again, the biochemical, the pH, LDH, and glucose will be similar to complicated parapneumonic effusion in empyema. Remember, pH can be less than 7 also in case of empyema. Okay. Now, what are the complications of empyema? Persistent pleural effusions lead to the formation of septa within the empyema and to fibrosis of the visceral pleura, which impairs lung expansion. That is called as fibrothorax. Okay, fibrosis of the pleural cavity. Other is, now there is pus that can rupture into the bronchus and patient will cough copious amount of pus. So that is nothing but bronchopleural fistula. Or the pus can rupture forwards into the through the chest wall, and it can be beneath the skin, or it can penetrate through the skin to form a sinus. That is nothing but empyema necessitans. And one more thing is, there can be pus with air. That is nothing but pneumothorax. Okay, these are the complications of empyema. What are the clinical features of empyema? There will be high grade fever, there will be chills, sweating, there will be neutrophilic leukocytosis, high C-reactive protein. There will be pleural pain, breathlessness, cough, and sputum, usually because of the underlying disease. And there can be copious purulent sputum if empyema ruptures into a bronchus. There will be clinical signs of pleural effusion. Okay. Now, what are the causes of this empyema? See these pie charts. Okay. In community, this can be community acquired or hospital acquired. Community acquired infection is usually due to streptococci 50% of the times. Other causes include enterobacteria and anaerobes staphylococci. Usually the empyema is mixed kind of thing. It will have gram positive also, gram negative also, and anaerobes also, but the predominant organism which is present in community acquired infection is streptococci. Okay. In hospital acquired infection, the predominant organism which is found is Staph aureus in more than in 50% of the cases, and that to MRSA in hospital acquired, and associated enterobacteria, enterococci can also be there. So you see these pie charts. See here in community acquired MRSA, the what do you call MRSA is very much less, and Streptococcus group contributes very much in these cases. Associated anaerobes, gram negative bacteria, you can also see Pseudomonas, you can see. In hospital acquired infection, see MRSA, how much it is contributing, 36%. Okay. And one thing you can also see here is anaerobes are associated in both. Usually it is a mixed infection. In hospital acquired, you should cover MRSA. That you should remember. Okay. Biochemical analysis results are similar to those of complicated parapneumonic effusion, but pH can be less than 7. Okay. That's about empyema. These are some pictures of fibrothorax. Okay. Fibrothorax. This is a chest X-ray. Left lung has not re-expanded due to visceral pleural thickening. Here it is not expanded. Okay, because of the thickening of the visceral pleura. The lung is not expanded. The patient was clinically well and the radiographic changes resolved spontaneously over 3 months. 3 months. Okay, this is the chest. See, this is the chest which is not expanded. You can see the what do you call that pleural line. Oxford says it as pleural line, lung line. Okay, it is not re-expanded, but over 3 months, changes resolved. Now you can't see some pleural line here. Okay. Here downside you can see a chest x-ray, okay, with lung unfolding upon itself due to fibrosis, lung unfolding upon itself due to visceral fibrosis, okay. That is called as comet tail sign. Comet, what will have one when some comet is falling from space, okay, it will have some stone like thing, and behind that will be some flares, no. So that you can see here in the chest CT, this is the comet and these are the tails of that comet. Comet tail sign, okay. That is lung is unfolding upon itself due to visceral pleural thickening. Then what is the treatment for that? The goals of the treatment are to reduce mortality, because mortality rate is very much high in empyema patients, and if there is effusion due to bacteria, our goal is to prevent the progression to empyema and the development of fibrothorax. Prevent the progression and development of fibrothorax, because fibrothorax will require surgical decortication, okay. So what treatment you will give in cases, okay, remember the treatment which is given. See, medical treatment alone has 70% chance of recovery only when there is uncomplicated parapneumonic effusion with small effusion, not large, okay. If it is complicated in large effusion, then you need ICD, okay. Antibiotic treatment for 3 to 4 weeks. So initially you will give empiric antibiotic therapy based upon community acquired or hospital acquired and covering the anaerobes. After that, based upon the susceptibility results, you will give the antibiotic, okay. Antimicrobial treatment used alone is effective only in small uncomplicated parapneumonic effusions. So example for empirical therapy, ceftriaxone 1 gram, which will cover gram positive as well as gram negative, along with metronidazole, which will cover anaerobes. Alternatives to that, piptas 4.5 3 times daily, or a carbapenem like meropenem 1 gram 3 times daily. If patient has penicillin allergy, then you can give fluoroquinolones plus metronidazole. So here it is there, for patients with penicillin allergy, you can use ciprofloxacin BD with metronidazole, okay, IV. You should not use aminoglycosides in case of uh, parapneumonic effusion or empyema, because they have very poor penetration into the pleural cavity. Second thing which you'll do is pleural drainage. When uncomplicated small, you shouldn't drain. Complicated parapneumonic effusion and empyema, you should have drainage along with antibiotics. So you should drain with small bore 12 to 14 French chest drain, which is connected to a water seal. And this is one thing which is a promising thing in trials. Intrapleural administration of tissue plasminogen activated 10 mg with DNS 5 mg twice daily for 3 days using a sterile technique. When it is done, when you the therapy, when there is septations, okay, when there are septations, usually these break the septa. These things will break the septa. So when antibiotics along with drainage fails, you use this one, okay. So usually TPA will be diluted in 30 ml of normal saline and DNase in 30 ml of normal water for injection. It is indicated for patients with complicated parapneumonic effusion or empyema if the antibiotic therapy and initial drainage have failed, okay. Or you can give all the three things combinedly in complicated parapneumonic effusion and empyema, all the three, okay. And in this one, it is important to administer both this TPA and DNS simultaneously, not separate or as monotherapy, okay. That you should remember. Now if all these three things fail, then you should go to surgical option. So surgical treatment, what are the things you do in surgery, what are the options available? video thoraco VATS, it is called as video assisted thoraco surgery. Okay, or open pleural drainage or thoracotomy. You make hole and drain through that. Thoracotomy is opening of thorax. Decortication, you remove visceral pleura and parietal pleura. That is decortication by surgery. So when it is indicated in symptomatic patients with persistent pleural fluid collections who had no adequate response to attempts of drainage, antimicrobial therapy, and TPA DNase. When these three fail, you do surgery. Moving forwards. So VATS is preferred. VATS is preferred. Video assisted thoracoscopic surgery is preferred because it has reduced hospital stay compared to open thoracotomy. So that was about the course, treatment, investigation of exudative pleural effusion due to bacterial infection. Now coming to exudative pleural effusion due to malignancy. So what are the causes? What are the causes? Most common cause are primary neoplasms. Second are metastatic cancers. There are four important secondary cancers metastatic. Number one is lung cancer, second is breast cancer, third is colon cancer, fourth is lymphoma. Okay, these four are common: colon, lymphoma, lung, and breast. Other include abdominal structure cancers like gastric cancer, pancreatic cancer, renal cancer, ovarian effusions, Meeks syndrome also known as. Okay, so cytology is the thing which you do to confirm whether there is malignancy, but cytology is only 50% sensitive. A second sample is takes the sensitivity to 60%, and if you are not confirmed by cytology, then you can do a image guided pleural cutting needle biopsy, nothing but just biopsy or thoracoscopy. These are the most sensitive techniques to identify malignancy. 80% these are sensitive: needle cutting biopsy and thoracoscopy, okay, to identify malignancy. So what is the treatment? What is the treatment? Sorry, what is the treatment? Treatment is often palliative and directed towards symptom management and management of the primary disease. That is the treatment. Okay. In asymptomatic patients with small effusion, just monitor. In symptomatic patients with progressive effusion, fluid level is increasing, tap the patient. Recurrent effusions. Now, recurrent effusions, there are two opinions. The recommended thing is, if there are recurrent effusion and the patient has less life expectancy, then you can then you can perform recurrent tapping. But if the patient has long life expectancy, you don't perform recurrent tapping. Okay, so the third one will show what you should do. Now, one more thing we should remember is, in malignancy there is effusion, so whether the lung is expandable or not expandable, so the procedure, the treatment depends also on that. So if the lungs are not expandable, recurrent effusions, lungs are expandable, then you can do pleurodesis. Pleurodesis is nothing but obliterating the pleural space by some chemical agent, and you glue both visceral and pleura, parietal pleura. Okay, chemical pleurodesis, this is that is called. This is one option. Second option is you keep an indwelling intrapleural catheter, so that if there is a current, the pleural fluid drains through that. So preferred one is pleurodesis in when the lungs are considered expandable. Now, in symptomatic patients where the lung is unexpandable, or if the pleurodesis is failed, in case when the lungs are expandable, then the last option which remains is indwelling intrapleural catheter. Oh, these are the things which we do in malignant pleural effusion, usually palliative in treating the malignancy. So I said at the beginning only that the most common cause of effusions are bacterial, mycobacterial, and malignancy. Okay, now coming to tubercular effusion. It can present in two ways. One is hypersensitivity tubercular pleuritis, and second one is tuberculous empyema. One more thing is that is nothing but tubercular parapneumonic effusion, where there is infection also and just effusion, no empyema, no secondary bacterial infection other than mycobacteria. Okay, so in hypersensitive tubercular pleurisy, what you will see is you see a delayed hypersensitive reaction to the mycobacteria in the pleural space. So the patient will have chest pain and minimal amount of pleural fluid, and minimal amount of pleural fluid they will have. And when you and it occurs in cases of primary infection, it is associated with a low pleural mycobacterial load. So chances of getting mycobacteria, it will be very less. Okay, that is nothing but hypersensitivity tubercular pleurisy. So you will, how you will diagnose then? It is nothing but pleural histology, which will reveal caseating granulomas. Along with that, you can also do ANA levels if there are small effusions also, and along with this ANA, IFN, if IGRA also you can do. IGRA, what is IGRA? Interferon gamma release assay. So these are just they suggest infection, but they do, IGRA will not suggest whether the infection is active or not. Okay, most gold standard is pleural histology in these type of cases. In tuberculous empyema, so what happens is caseating granuloma will rupture from the lung into the pleural space. Along with that, so rupture from the lung to the pleural cavity, along with that there will be secondary bacterial infection. So there is mycobacteria also and secondary bacteria also. So co-infection will be there. So that will cause empyema, pus. Okay, pus. So what is the treatment? So here you just give anti-tubercular therapy. Okay, and here you should give along with anti-tubercular therapy in empyema. You should give antibiotics in addition to the anti-tubercular treatment. Okay, that is the thing. Now the other two things which we see in practice are, one is Chylothorax, second one is Hemothorax. First, coming to Chylothorax, remember one more thing is Psuedochylothorax. Psuedochylothorax. Okay, true Chylothorax and Psuedochylothorax. One is true Chylothorax, one is Psuedochylothorax. How you will differentiate between two? By two things: levels of triglyceride, levels of cholesterol, one more is cholesterol crystals. Okay, cholesterol crystals. By these three things you will differentiate between true chylothorax and pseudocylothorax. Pseudocylothorax usually happens in chronic effusions. Whenever there is chronic effusions, there is deposition of cholesterol in those. That's why that will appear milky. Okay, now chylothorax is a pleural effusion caused by the leakage of lymphatic fluid into the pleural space, either due to rupture of thoracic duct or due to obstruction of lymphatic vessels. What are the causes? Remember, most common two causes are, one is trauma, one is malignancy. One is malignancy or tuberculosis also. Okay, trauma, malignancy, or some lymph node which is compressing the thoracic duct or obstructing the lymphatic vessels can also cause chylothorax. But most common is trauma, malignancy, tuberculosis. These are the three most common causes. Okay, trauma, either due to surgery or chest trauma, catheterization to the superior vena cava for putting the central line. Okay, malignancy में lymphoma or metastasis of other cancers, and third one is tuberculosis. Okay, third one is tuberculosis. trauma, malignancy, tuberculosis. One more, lymphangiomyomatosis. Okay. So how do you diagnose pleural fluid analysis? Fluid is milky white, odorless, contains chylomicrons. Is these three you should remember: triglyceride, no cholesterol crystals, and cholesterol levels. To differentiate between true chylothorax and pseudochylothorax. Pseudochylothorax occurs in any chronic effusion. True chylothorax will have triglyceride more than 110 milligram per deciliter. Usually, remember as a general thing, in true chylothorax, triglycerides will be high because cholesterol is not deposited. In chronic effusions, cholesterol is deposited. That's why cholesterol will be high, triglycerides will be low. Okay. So in true chylothorax, triglycerides will be high, more than 110, and cholesterol crystals will be absent. Cholesterol level is less than generally 100 milligram per deciliter. This should be differentiated from pseudochylothorax. Accumulation of cholesterol in any chronic effusion, that is known as pseudochylothorax, like tuberculosis and rheumatoid arthritis. How? Now see here, cholesterol will be high, more than 200 milligram per deciliter. Cholesterol crystals will be present. Triglyceride will be less than 50. There it is 110. And cholesterol level, it is 100, less than 100. Okay. And cholesterol crystals will be absent. That's how you differentiate between true chylothorax and pseudochylothorax. So what is the treatment for chylothorax? Pleural drainage and management of the underlying disturbances. Okay, pleural drainage and treating the cause. Instruction on a high protein, low fat, less than 10 gram per daily diet are recommended. Low fat, high protein. Total parenteral nutrition, TPN, to reduce lymph production. Somatostatin and octreotide can be used as adjunctive therapies. In two-thirds of, this is important word, in two-thirds of patients, chylothorax resolves after 12 to 14 days. In two-thirds, approximately 75% of patients, chylothorax will be resolved in 2 weeks. Okay, if it doesn't resolve, then a constant lymph outflow more than 500 ml half liter per day outflow through the ICD is an indication for surgical treatment. If it doesn't resolve, or if the drainage is very much high, then surgical treatment is required. That was about chylothorax. Okay. Last one is coming to the hemothorax. Okay. Hemothorax. By name only you understand blood in the pleural space. It is the presence of blood in pleural space due to injury. The presence of blood in the pleural due to injury, either due to traumatic or iatrogenic. Okay. How do you, now here also there is true hemothorax, pseudohemothorax. True hemothorax, pseudohemothorax. You will differentiate true and pseudo from hematocrit levels. Okay. So if the hematocrit levels of the pleural fluid is more than 15 or equal to or more than 50% of the peripheral blood hematocrit, then it is true hemothorax due to injury or iatrogenic. And if it is less than 50% of the peripheral hematocrit, then it is false or pseudo hemothorax. Okay, what is pseudomyothorax we will learn here. Hematocrit value is used to distinguish hemothorax from a bloody exudate, which is most frequently caused by malignancy, pulmonary embolism, infarction. Okay, when at all you see this bloody hemothorax, bloody exudate, pseudo hemothorax, one as given here in malignancy, bloody. Okay, in malignancy. Second, pulmonary embolism. Third, connective tissue disorder like systemic lupus erythematosus and rheumatoid arthritis. So, or vasculitis also, vasculitis. Okay, in these three you will see bloody exudate, pseudo hemothorax. True hemothorax you will see in injury to the chest wall. Okay, symptoms are the same as in the case of pleural effusion. Symptoms, breathlessness or chest pain, and sometimes may be accompanied by manifestations of blood loss because there is bleeding. So there can be anemia, tachycardia and hypotension because of blood loss, volume loss. Tachycardia and hypotension can also be there along with breathlessness, pleuritic pain. Okay, what are the complications? Again, same complications. They can be bacterial infection in the hemothorax progressing to empyema and fibrothorax. So bacterial infection which can progress to empyema and fibrothorax. That is the complication of hemothorax, which can be true or pseudo. Pseudo you can see in malignancy, in pulmonary embolism, in blood pressure disorders. So what is the treatment? What is the treatment? Treatment is urgent pleural drainage with large bore. In complicated is small bore 12 to 14. Here it is more than 16 French. More than 16 French chest tube placement and drainage to evacuate the pleural space are strongly recommended. Urgent drainage is required. Now, this is drainage. Drainage is the main thing which you do in hemothorax. When do you require video thoracoscopy or thoracotomy? Indications of video VATS. Indication of VATS or thoracotomy. Thoracotomy. So these include ineffective drainage. Ineffective drainage meaning it is blood is draining through the ICD, but still it is increasing in pleural cavity also. That is ineffective drainage. Okay. Persistent bleeding. Bleeding is not stopping only. Blood loss. What is persistent bleeding? Blood loss of more than approximately half liter per hour for 2 to 3 hours, or blood loss of approximately 250 ml for 6 hours. For 6 hours. 250 ml per hour for 6 hours. Blood loss of approximately 400 ml per hour. Okay, for 2 to 3 hours. Okay, this is one condition. Second condition is blood loss of approximately 250 ml average I am taking per hour for 6 hours. So these are the criteria for video thoracoscopy or thoracotomy. That is one thing. So ineffective drainage, persistent bleeding, suspected cardiac tamponade. Suspected cardiac tamponade. So what will happen in cardiac tamponade? There will be Beck's triad, raised JVP, muffled heart sounds, hypotension. This is nothing but Beck's triad. Okay, so when there is suspicion of cardiac tamponade, you should tap. Damage to major vessels like aorta, pulmonary artery. When there is damage to these vessels and bleeding is from these, then you should urgently do surgery. Necrotic lesions in the pleura, chest wounds, large air leak from the chest tube drainage. Large air leak from the chest tube drainage. These are the indications for video thoracoscopy or thoracotomy. Okay, you should remember this one. Ineffective drainage, persistent bleeding, damage to major vessels, chest wounds. Okay, chest wounds, suspected cardiac tamponade, large air leak. Okay, prompt removal of blood prevents fibrothorax. So if you don't remove the blood, then the hemothorax will develop onto fibrothorax, which is a very bad thing which is going to happen, and there is no solution for this except surgery. Okay, So that concludes our class on specific consideration on pleural effusion. Make sure to comment on how the teaching learning is going on and how the notes are, and if any improvement is required, we will do it, inshallah. So thank you for listening till now. Goodbye. We will come again in during taking a next topic. Okay, thank you.